Alterations in integument, pressure injuries. The National Pressure Ulcer Advisory Panel prefers the term pressure injuries for what are commonly called bed sores, decubitus ulcers, or pressure ulcers or pressure sores. These are going to be localized areas of tissue necrosis that develop when soft tissue is compressed between a bony prominence and an external surface for a prolonged period. Now, if you look at this slide, it's going to show you some of the common pressure points that we have to monitor in our clients, especially those that are going to be at high risk for pressure injuries. Pressure injuries develop when blood flow to an area is reduced as the skin is compressed between a bony prominence and the support surface. It can also be caused by shearing forces. In other words, that friction that's caused when you slide someone up in bed. So you should always use the lift sheet to pull clients up in bed. Pressure injuries are expensive to treat and they result in longer hospital stays. They also increase the likelihood of placement in a long-term care facility and increase mortality. Other potential causes of pressure injuries include chemical irritants such as urine or potential sedation because they are laying in one place for an extended period of time or one position. And poor nutrition. We do know that people that are malnourished are at a higher risk for developing pressure injuries. Pressure injuries can occur in a client, even in a healthy person, in a 2-hour time frame. To prevent pressure injuries, it's important to identify clients that are going to be at risk and then initiate prevention measures. The most important thing to prevent pressure injuries is offloading. In other words, the removal of the pressure. Two common tools that may help predict pressure injuries are the Norton scale and the Braden scale. So some facilities require the Braden scale to be completed upon admission just to determine if they are at an increased risk for the development of pressure injuries. There is a copy of the Braden scale within Blackboard. I highly recommend that you look this up and be familiar with it so you understand the things that we're looking for. So prevention includes identifying those that are most at risk and then preventing. We need to reposition the client in bed at least every 2 hours. Some clients may require more frequent repositioning. We should position the client so they are not resting on pressure points of the skin. So if you forgot what those are, look at that first slide. Teach the clients that are in wheelchairs to shift their weight at least every 15 minutes if they're able. Developing pressure injuries on the ischial tuberosities can be very difficult to treat. Clients that cannot do this, we need to be repositioning them at least every hour for those wheelchair-bound clients. Make sure that we keep bed linens dry, smooth, and free of wrinkles. We need to gently cleanse the skin when it's soiled and at regular intervals use warm water and a mild cleansing agent. We should never scrub. And if we're using barrier cream to help keep urine and or feces off of the skin to prevent irritation, then never scrub that barrier cream off. We just cleanse the urine, cleanse the feces off of that barrier cream and leave the barrier cream on. We should use moisturizers and lubricants, protective films, barriers, and dressings to help reduce friction and shearing. For example, clients that are at an increased risk for pressure injuries, we can put the adhesive foam pads over those areas. It provides a little bit of cushion and also helps the skin slide a little bit better, so those shearing forces are reduced. It has been proven to help reduce the incidence of skin or pressure injuries. Measures that enhance patient mobility should be initiated, such as trapeze bars or keeping the upper uh, bed rails up to allow the client to use those to help with repositioning. In bed, we should keep the head lowered. 30 degrees would be a good level to help reduce shearing forces that can be caused as the patient slides down in the bed. We can apply special surfaces to the bed or to the chair to reduce pressure, such as an egg crate foam. The minimum thickness needs to be 2 inches. Static air mattresses, alternating air mattresses, gel pads, the fluidized air mattresses or water mattresses can all help reduce pressure. Sheepskin boots can help prevent shearing forces to the feet, and pillows or other devices to help prevent heel pressure. Protecting the skin from moisture using those absorbent pads or briefs for incontinence. Instructing the client and family about risk factors and strategies for prevention of pressure injuries. Be aware that some items, such as rubber rings, actually increase pressure, and they should not be used to elevate the sacral areas. If you think about it, when you sit on the toilet seat, if you sit there for an extended period of time, it can actually cause some uh, edema and pressure of the backs of the thighs and the buttocks due to that increased pressure while you're sitting. So don't use the inflatable rubber rings or inflatable plastic rings. Provide appropriate nutrition and hydration. We may need to increase protein in a client who's malnourished or who has a pressure injury. This will, again, help promote healing. Using those small, frequent meals to improve the client's intake. And if they have issues with healing, we can supplement them with vitamin A, vitamin C, or zinc. If you look at the picture here, there's some pressure relieving devices that are being used. The very bottom picture, you have the uh, pillow that is designed especially to elevate the heels off of the bed. If you look at the picture in the upper left, you have a boot that's placed on the foot. It has a hole cut out for the heel itself, and it's actually elevating it off of the surface of the bed itself. And using that lift sheet to reposition the client in the other picture. A pressure injury usually will begin as erythema, in other words, redness, and it's a sign that the area has impaired blood flow. If pressure injuries develop despite all preventative measures, then we have to assess the stage and describe it precisely. Now, pressure injuries only. This is the only type of wound that we're going to stage. We have different classifications for other types of wounds, such as a DFU, a diabetic foot ulcer, or a skin tear. But pressure injuries are staged. Stage 1 pressure injury. This is only erythema. Erythema that does not blanch when you press it. In other words, it does not turn white when you push on it. That is a stage 1. The coloration may be red to a dusky blue. If you look at the picture in the upper left, this is a stage 1. The skin is usually going to be intact. The shape is usually irregular, and it may reflect the shape of the object that created the pressure. For example, if they were potentially lying on a tube, the shape of the pressure wound may be the shape of a tube. Pain and tenderness might be present with swelling or hardening of the tissue, and it might be warm to the touch. Again, there's little destruction of the tissue, and this condition is reversible if we remove the pressure. A stage 2 pressure injury. This is a partial thickness skin loss. In other words, that very top layer of the skin has come off, and it reveals the epithelial tissue. This wound is going to be very shallow. It may be appearing blistered or cracked or kind of abraded, aka scraped. That ulcer might be surrounded by a broad, irregular, painful reddened area. Again, that might be warmer than usual to touch. This stage 2, once again, is the only type of pressure injury with epithelial tissue. The only type. Again, it's very shallow. A stage 2 pressure injury can also be a blister over a pressure point that is filled with fluid, as long as it's not blood, because then it's something else. So a fluid-filled blister, we call it a serum-filled blister, is also a stage 2 pressure injury. Stage 3, we see full thickness skin loss. We've got damage to the dermis and the subcutaneous tissue, and over 50% of the wound bed is granulation tissue. We can have other types of a wound bed present as long as we have 50% granulation tissue. Then it's a stage 3. A stage 3 will appear like a crater, so there's going to be a little bit of depth to it. Has a very distinct outer margin. Again, these wounds can be draining, but we're going to see that red granulation tissue. At least 50% of that wound bed is granulation tissue. A stage 4 is exactly like a stage 3 with one difference. Now we can either see or palpate some underlying structures that can include muscle, tendon, the ligament, or bone. So again, we have to have over 50% granulation tissue, but we can either now see or feel some of those deeper structures. Once again, that's muscle, tendon, ligament, or bone. Excuse me. Again, this is full thickness. An unstageable pressure injury has a wound bed that is covered with more than 50% eschar or slough. In other words, if you remember, it's that dead tissue, that slimy, whitish, tan, yellow, moist tissue that's adherent to the wound bed, or that dark, leathery, scab-like looking covering. 50% of the wound bed has to be covered by slough or eschar. So if you're looking at these pictures, that's going to be your middle right picture. You can see that over 50% of that wound bed is slough. It does look like we have some granulation tissue and maybe a little bit of epithelial tissue uh, also with that wound bed, but the majority of it is slough. So the key number there is over 50%. If we were to remove that slough, if we were to remove any eschar there, we know there would be at least a stage 3 wound. So we would have granulation tissue underneath it. Then we have the deep tissue injury. If you look in the lower right-hand corner, again, this kind of looks like a bruise, but it's not. It's usually purple in color. The skin is usually intact. It is always going to be over a pressure area. Again, it's dark purple, could also be in red in color. It could also be an intact blister that is filled with blood. The blister originally may have been filled with serum, so just a fluid-filled blister, but then at some point it becomes filled with blood. So then it has evolved from a stage 2 into a DTI. If a DTI were to open, we know that there would be at least a stage 3 pressure injury. However, there's a lot of DTIs that can resolve without ever opening. I do want you to know that we can go from a smaller to a larger number when we're staging pressure injuries. We can go from a 1 to a 3, or a 2 to a 3, 2 to a 4, a 2 to a DTI. But we cannot go from a stage 4 to a stage 1, or a stage 3 to a stage 2. It's always going to be the smaller number can get bigger, but the bigger number can never get smaller. We would call it a resolving stage 4 or resolving stage 3. This is a push tool. It was developed by the National Pressure Ulcer Advisory Panel, and we use it as a measurement tool to identify improvement or deterioration in pressure injuries. We look at the size of the wound, so we're looking at the length. We are going to multiply the length of the wound by the width of the wound, and then we match that with the appropriate score. We're looking at the amount of exudate, match that with the appropriate score, and then we identify the tissue type and match that up with the appropriate score. Then we total those 3 scores to determine the push score. Again, this is going to give us a measurement, and nurses like to have measurements to determine improvement or deterioration or maintenance. So it's a good tool. This is usually done once a week, and we will measure wounds once a week. So how do we care for pressure injuries once they do occur? Again, the first step in treating pressure injuries is to continue all the preventive measures. We need to offload, get the pressure off of that particular area. Wound healing will be enhanced when the wound and the surrounding tissues are all offloaded, because we're trying to improve circulation to that area. Supportive care will consist of measures to treat comorbidities, in other words, other client illnesses such as diabetes or heart disease. Nutrition has to be assessed to make sure the client has an adequate intake, especially of protein. And again, we may require supplements to make sure they're getting sufficient amounts. We clean the wound bed with mild soap and water, or potentially normal saline, or maybe even a commercialized wound cleanser. Consider avoiding the use of pastes, creams, ointments, and powders because those things might promote infection in the ulcer. However, there are ointments such as zinc oxide that can be highly effective when we're treating like a stage 2 or a really small stage 3 pressure injury. We should avoid using alcohol or antiseptics or disinfectants, um, topical and oral antibiotics, and massage unless the wound is exhibiting signs of infection. The most effective dressing is a dressing that will provide a moist environment, again, not wet, not dry, to maintain a temperature close to body temperature. The more frequently we remove a dressing, the longer it will take a wound to heal. Healing will occur once the wound has reached the normal body temperature. And if we're removing the dressing, we're cooling that wound down. And it can take up to 4 hours to get it back to the appropriate temperature where healing is going to occur. So we want dressings that can stay on there at least for a couple of days. The goal of debridement is going to be the removal of slough or eschar, and we want to reach that healthy pink granulation tissue. If you look at the picture in the slide, they are debriding slough, and you can see that nice healthy granulation tissue underneath it. They might use tweezers or pickups to pull the slough up and then snip it off with a scalpel or scissors. If it's a small area, they can use a curette, which is a little metal circular device attached to a plastic handle. It has a hole in the middle, and that hole in the middle has sharp edges, and they kind of scrape that across the surface of the wound to get some very superficial slough off. But if we see bleeding, bleeding is good because then we know we have reached that nice healthy granulation tissue. We just don't want it to hemorrhage. In the past, and you're still going to find there are some providers that order wet to dry dressings to be used for debridement. So you put a wet dressing over this wound, and then as it dries out, then it's going to, that slough will adhere to that dressing, and then you pull it off and it pulls off that slough. And that's a very archaic, in other words, old-fashioned type treatment. It traumatizes the wound. So it's not only removing the slough, it's also removing healthy granulation tissue. And that just creates a longer period of time for wound healing to occur. So again, you're still going to see a lot of providers order that dressing, but your wound care nurses will never order that dressing, and they will discourage that type of dressing on these clients. Again, debridement can be accomplished a variety of ways. We can do it chemically. There is an ointment out there called Santyl. It's really slow, but it will cause the dissolving of that slough. We can do it biologically, and this is with the use of medical grade maggots. And yes, I mean fly larvae. They are actually very effective at removing dead and necrotic tissue and getting a wound down to that good healthy granulation tissue. They're basically placed in a wound and then covered with a dressing to keep them in that area. They will not eat the healthy tissue, just the dead tissue. Or we can debride, and debridement is basically removal of that non-viable tissue again with those sharp instruments, as I described a few minutes ago. And understand that wounds may require serial debridements. In other words, we're debriding every 2 or 3 times that we change the dressing, etc. And now your post-test.